The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/HKY860. Downloadable resources are also available.
Hello, I'm Carl Anderson at the University of Texas Medical Branch in Galveston, Texas, and I'm happy to welcome you to this educational activity which is entitled Acute Hepatic Porphyria, Disease, Diagnosis, and Revelations Regarding the Role of siRNA Therapy. So let's begin with a visual exploration of the diagnosis and disease burden associated with acute hepatic porphyria, or AHP. So what is acute hepatic porphyria? Acute hepatic porphyria, or AHP, is a group of 4 rare inherited disorders, and they affect about 5 individuals out of 100,000 as a rough estimate. These disorders include acute intermittent porphyria, or AIP, which is the most common, hereditary copper porphyria, or HCP, and variegate porphyria, or VP, and ALAD porphyria, which we abbreviate ADP. So AHP is caused by mutations in enzymes of the heme biosynthetic pathway, particularly in the liver. They are associated with acute neurovisceral symptoms, which we call attacks, such as severe abdominal pain, mental status changes, seizures, and paralysis due to motor neuropathy. And this condition can be severe and life-threatening. Individuals with AHP commonly face problems such as misdiagnosis, unnecessary medical procedures, severe pain, inadequate treatment, emotional stress, depression, anxiety, and reduced quality of life. It's not uncommon for individuals with AHP to receive insufficient pain treatment in emergency departments and elsewhere because they are labeled as drug-seeking. Often their pain is out of proportion to their physical findings. So the heme biosynthetic pathway contains 8 enzymes, and as I mentioned, there are 4 enzymes that, when they're deficient, can result in AHP. AIP, acute intermittent porphyria, accounts for about 80% of the symptomatic cases of AHP. It's autosomal dominant inheritance with low penetrance, so many patients who inherit mutations never develop symptoms. And the enzyme porphobilinogen deaminase, which is the 3rd enzyme in the pathway, is reduced by about 50%. Hereditary copper porphyria and variegate porphyria are also autosomal dominant disorders with low penetrance, and the enzymes affected are later in the pathway, copper porphyrogen oxidase and protoporphyrogen oxidase, and these are also reduced by about 50%. The 4th is ALAD porphyria, which is very rare. There have only been 8 cases identified in the world. And this, although the symptoms can be the same, it's an autosomal recessive disorder, and it's due to deficiency of the 2nd enzyme in the pathway, ALA dehydratase.
Aminolevulinate synthase 1, ALAS1, catalyzes the first step, converting glycine and succinyl coenzyme A to delta-aminolevulinic acid, ALA. In individuals with acute hepatic porphyria, AHP, a genetic mutation leads to an enzyme with reduced activity at one of the later steps. When an event induces ALAS1 expression, the slow enzyme cannot keep pace, causing a buildup of heme precursors from previous steps. Some of these precursors, particularly ALA and porphobilinogen, PBG, are potentially neurotoxic and associated with the painful attacks characteristic of AHP.
So there are a number of triggers that are important in AHP and in explaining the pathophysiology, and these act particularly on ALAS1 in the liver and cause upregulation of that enzyme. These can include stress, metabolic and emotional stress, fasting and dietary restriction, alcohol and other substances, smoking, which contains chemicals that can induce ALAS1, hormones, particularly progesterone and progestins, and also a number of medications. We know certain medications are definitely unsafe. These include barbiturates, and phenytoin, and these are examples of drugs that induce heme synthesis in the liver because they upregulate cytochrome P450 enzymes in the liver, and most of the heme that's made in the liver is actually used for cytochrome P450 enzymes, or CYPs. So any drug that induces CYPs in the liver is very likely to upregulate ALAS1 and make AHP worse. There are a number of sources for information on what drugs are safe and unsafe, particularly on websites of the American Porphyria Foundation and the European Porphyria Network. So the presentation of AHP, it has been described as a classic triad of neurovisceral symptoms, but the most important presentation is abdominal pain. It's by far the most common symptom, and it can present in the absence of other symptoms. It's usually severe and recurrent. Often the physical exam is not very impressive because it's neuropathic pain without inflammation. The presence of factors such as a female in reproductive age, or in the luteal phase of the menstrual cycle, or taking medications that are known to be unsafe may be a clue, but patients can present without these features. Peripheral neuropathy is manifested by muscle weakness and also by pain in the extremities, which may be severe, again, without much in the way of physical findings. Motor weakness is hard to recognize because it often begins proximally in the upper extremities, and it can progress, if the disease is not recognized and treated, to paresis involving all extremities, and it can even progress to respiratory paralysis. It's reversible with treatment. Even advanced paralysis is potentially completely reversible. They can have a variety of effects on the central and autonomic nervous system. Hypothalamic involvement may occur with syndrome of inappropriate ADH secretion causing hyponatremia. Tachycardia is the most common physical sign, although it's not always present. Hypertension is common. Other clues can include reddish or brown urine, which is a good clue, but it's not necessarily present. The disease can cause renal impairment, and so that may be present. It can cause abnormal liver function tests, and patients commonly have chronic symptoms between attacks, and this further reduces quality of life. In terms of diagnosis, the clue can be from the history, both the personal history and the family history. The physical examination is often not very informative because it's neuropathic. All the symptoms are neuropathic. It's important to check for proximal weakness in the upper extremities. The ordinary obtained laboratory testing and urine testing is usually unrevealing. They may be hyponatremic, and that can be a clue, but severe attacks can occur with normal electrolytes. So the diagnosis can readily be made, particularly by measuring porphobilinogen, or PBG, which is a pyrrole, not a porphyrin. We also measure ALA, but that's usually less elevated than PBG, so it's not essential to measure ALA. In addition to PBG, we recommend measuring porphyrins because sometimes porphyrins remain elevated longer than PBG. So this is done by a quantitative measurement of PBG on a spot urine sample. Collecting a 24-hour urine is not necessary because the elevation is usually quite marked. The initial report can be expressed as a concentration, amount per liter, but a final report should be normalized to creatinine, which corrects for various degrees of dilution of urine samples. The levels usually remain elevated, particularly in AIP, between repeated attacks, but they can drop to normal. So if the first-line testing is positive, then second-line testing is needed. A high PBG means the patient does have either AIP, HCP, or VP, but measurement of plasma porphyrins and fecal porphyrins is necessary to differentiate those three disorders, because they are markedly elevated in the latter two disorders. Afterwards, it's important to do genetic testing. This is important because it confirms the diagnosis. It also enables identifying other family members who are also heterozygous for AIP, HCP, or VP, and are at some risk to develop attacks at a later time. So AHP is not commonly considered even when patients present with typical symptoms, and that is because the disease is rare and also because the symptoms may be typical, but they're very nonspecific. So elevation in PBG and measuring PBG is not considered part of standard workups, particularly for conditions such as abdominal pain. And we see many patients with unexplained abdominal pain, even after an initial workup in the emergency room. And after an initial workup that's negative, these patients really should be screened for porphyrobilinogen elevation because that test gives you a definite answer and it enables the patient to be treated for a life-threatening illness. And the treatment for this condition is specific. It's important that they be tested when they're sick. And also, diagnosis should be considered even if their level of clinical suspicion is not high. And so I think porphyrobilinogen and porphyrin measurements need to be considered more often as part of the standard workup, particularly for abdominal pain, also patients with neuropathy. Now let's hear a patient's perspective on living with AIP, which is one of the disorders classified as acute hepatic porphyria.
Well, it was a bit of a long one, though not as long as others. I have a pretty significant family history of acute intermittent porphyria. My grandmother died from the disease in the early 1960s at the age of 28. My mother was diagnosed in 1995. So around 2002, I began having some symptoms that I wasn't quite sure what it was. I knew it was similar to my mother's, but I sort of just kind of ignored it and put it off because they weren't very severe. They sort of bounced around a little bit here and there. Then in 2004, they got a little bit more severe. I went to my doctor and we thought perhaps there was some gallbladder issues. So we did the diagnostics with that, found that my gallbladder was draining slow. It went on for a little while, still having problems with it. So I ended up having it removed. And at the time we thought maybe we had fixed the issue because what they'd found when they did the surgery was that my bile duct was actually quite small compared to what it should be. But unfortunately that didn't fix it. My symptoms continued to progress, getting slowly worse and worse until 2008. Then I had a severe attack. I had gone through checking to see if it was AIP a few times. The first time we tested for it, I think it was probably in 2005. Unfortunately, when I was tested, I was not symptomatic at the time. So when my urine PBGs came back, they came back only mildly elevated. So we thought that probably wasn't the problem. At the time, I really didn't know much about porphyria, so I didn't realize that I needed to be symptomatic in order for that test to really be very accurate. Then in 2008, my symptoms got much, much worse. We ran the gamut of trying to figure out what was going on. They thought maybe I had Crohn's disease. I was tested for that. They thought maybe I had prostatitis a few times. It wasn't that. They thought finally maybe you've got a severe infection in your intestines. They put me on antibiotics. It didn't work, so they put me on Flagyl, which I found out later was a medication I should not be on. And that really got things going. And I was in and out of the ER. Finally, they decided to test me again, and my diagnosis came back. I was tested twice, did the 24-hour urine collections in about a period of 2 weeks, and both of those came back with very high elevated PBG and ALA in the urine. Originally, it was some mild abdominal pain in the upper right quadrant. As my symptoms progressed, I would get more severe pain in both the lower quadrants. As time went on and the disease progressed, I began developing peripheral neuropathy, particularly in the hands. I had that got really severe. It was to the point that I had actually planned to tourniquet both arms, call 911, and then cut my hands off because at the time I was still getting difficulty getting treatment. When the GI doctor I was seeing at the time, I told him that, he finally decided to kind of get in gear and referred me to a hematologist who knew what was going on, so I was able to get better treatment. I was fortunate enough never to have seizures, but I did have some muscle weakness, extreme fatigue, nausea, severe nausea and vomiting. It was horrible. My quality of life went way, way down. After I went on disability, I hardly got out of the house. There were days where I felt halfway decent. I could do a few things around the house, maybe outside, but then I would get fatigued so quick I would have to go in and sleep. It got to the point where I was almost nearly bedridden. I would be in bed for a big chunk of the day, all night. If I got up, I could do maybe a few things, and then I was in the chair sleeping with the TV on. I hardly went anywhere, hardly did anything. I pretty much quit going to church. I had no social life to speak of. And of course, that's difficult in a marriage. It was difficult in the relationship with my kids and the rest of my family as well, because a lot of people didn't really understand how sick I was. You know, they would look at you and they would say, well, you don't look that sick. It can't be that bad. Well, it's, you know, because you can't see pain. They didn't see me when I would have the severe nausea and vomiting. They wouldn't see me in the hospital with, you know, the urine coming out of me looking like coffee and all the vomiting I would do. People don't understand because they don't see it.
So, in the next part of this activity, let's examine treatment options for AHP, including a recently approved siRNA therapy. Hospitalization is usually necessary for these attacks because the patients are very ill, and being in the hospital facilitates treatment of severe symptoms, including administration of adequate doses of narcotics, treatment of CNS manifestations, use of IV therapies, and monitoring for progression of muscle weakness and levels of electrolytes. And hyponatremia can be corrected carefully and avoided by judicious use of IV fluids. I'll next discuss what we do to prevent attacks if patients after diagnosis continue to have frequent recurring attacks of AHP. We should always try to eliminate triggers such as harmful medications, infections, dietary habits, and smoking. Carbohydrate loading may be effective in terms of aborting an attack, and patients often increase their carbohydrate intake if they think they're starting to get an attack. There's little evidence that's that effective, and a problem with that is it can often lead to weight gain. And these patients can have increased body weight, which is difficult to manage because dietary restriction can make them worse. So dietary advice is very important, and we often recommend they see a dietitian. In terms of prophylaxis, we think about prophylaxis when patients continue to have attacks, particularly after we remove triggers that we can identify. There are a small segment of women who have frequent attacks during the luteal phase of the menstrual cycle when progesterone levels are high. And if these occur on a regular basis, we consider using GnRH analogs, or now we consider also using givosiran. Sometimes low-dose hormonal contraceptives can be used that contain less progesterone than the older oral contraceptives. And Hemon prophylaxis can also be given. We use that often for cyclic attacks as well as for non-cyclic attacks if prevention is needed.
Well, the first thing you want to do is stay well hydrated. What set off my major attack in 2014 was I got very dehydrated at work. So on top of staying well hydrated, the D10 and normal saline did help some for a while. I was getting heme infusions quite often. A higher carbohydrate diet, and then if you start feeling tired or if you start feeling some pain, I would back off of what I was doing. You have to rest a lot more. It doesn't take a lot sometimes to set things off when you're already sort of hovering right on the edge of it.
So Hemon prophylaxis can be given as a single infusion once a week, or it can be arranged on demand. So if a patient starts to get symptoms, they come in immediately, and sometimes they respond to one infusion, and the attack resolves quickly. Ordinarily, treatment of an acute attack with Hemon requires 3, 4, or more doses of daily Hemon. Hemon must be given intravenously, so a port for delivery is needed, and many patients who have a lot of attacks have an IV port. Some patients develop iron overload after many doses of Hemon, so their ferritin needs to be monitored. So givosiran, which is given subcutaneously as a single monthly injection, has many advantages. It's a long-acting drug as opposed to Hemon, which is short-acting, and it can be very effective in preventing recurrent attacks in these patients. It does require monitoring. Rarely patients have developed anaphylaxis. They can get injection site reactions, which are usually not too troublesome. Liver function and renal function are affected by AHP itself, and it's been found that these are more often abnormal with givosiran than with placebo, so that needs to be monitored if patients are continued on this medication. Liver transplantation can be curative, but it's a treatment of last resort when nothing else works, and we're hopeful that givosiran will decrease the need for liver transplantation in these patients. So the treatments available are carbohydrate loading, Hemon, and givosiran, which all downregulate hepatic ALAS1. So the rationale for reducing ALA synthase in the liver, and this occurs by repression of synthesis of this enzyme rather than inhibition of this enzyme. This can decrease the amount of ALA and PBG that is produced, so it decreases the significance of the partial enzyme deficiency in these patients. Intravenous Hemon is an enzyme repressor rather than inhibitor, and it's derived from human hemoglobin by processing human whole blood samples or units of whole blood. It's a highly purified product and doesn't contain other blood substances. And it reconstitutes this regulatory heme pool in the liver that acts on ALAS1 synthesis. It's approved for amelioration of attacks, particularly recurrent attacks in women. However, it's been found that it's effective for attacks due to any cause in these patients. And it also can be used during pregnancy, and it can be used for prophylaxis. Usually there are no prominent side effects. If it's infused into a small vein, patients can get infusion site phlebitis, and this can be prevented by reconstituting the product with human albumin rather than sterile water, because this stabilizes it and prevents degradation of the hemin, which is what causes the phlebitis. The degradation products can also cause an anticoagulant effect, and that's also prevented by using albumin. So Hemon was not subjected to double-blind placebo-controlled trials, but there have been a number of studies demonstrating efficacy, such as a study in Europe, which showed that prompt treatment with Hemon resulted in improvement in a high percentage of patients. So now let's take a look at the actions of givosiran, an siRNA therapy for AHP in 3D.
One approach to preventing a buildup of neurotoxic heme precursors is to prevent production of ALAS1. Givosiran is an ALAS1-directed double-stranded small interfering RNA, siRNA. It also includes covalently linked N-acetylgalactosamine GalNAc residues that bind to specific receptors on hepatocytes, targeting givosiran to the liver. Once in the liver, givosiran is cleaved and a single strand is incorporated into the RNA-induced silencing complex, RISC. Multiple ALAS1 mRNA molecules bind to the RISC-associated RNA, where they are degraded, resulting in decreased expression of the ALAS1 protein.
So givosiran has been subjected to high-quality studies, particularly the phase 3 clinical trial, which was a double-blind placebo-controlled study. The treatment period was 6 months, and patients were either treated with placebo or givosiran, 2.5 milligrams per kilogram subcutaneously, and it enrolled only patients who were symptomatic, particularly with recurrent attacks, or were on Hemon to prevent recurrent attacks. Any patients on Hemon needed to stop the Hemon prophylaxis during the study. There were 94 patients totally. Most of these had AIP, as might be expected, because AIP is more common. It also tends to be more severe than the other AHPs. In the phase 3 clinical trial, during the double-blind placebo-controlled period, the annualized attack rate was much lower with givosiran, 3.2, than with placebo, 12.5. So it was 74% lower with givosiran, which is a dramatic difference and highly statistically significant. The phase 3 trial also showed efficacy in terms of reduction of urinary ALA and PBG levels. In the placebo group, there was no decrease in these levels, but there was marked decrease in patients treated with givosiran. As I mentioned before, the mean annualized attack rate was much lower with givosiran than with placebo. And also the annualized number of days of Hemon use was decreased significantly. And the change or decrease in daily worst pain score was markedly better with givosiran than with placebo. In terms of safety, adverse events occurred in both groups with approximately the same frequency. Very few adverse events leading to discontinuation of therapy. There were no deaths. Hepatic and renal effects were more common in the givosiran group than the placebo group. This is a complicated and severe case. This patient was a Caucasian female who currently is 44 years old. She had a history of obesity, polycystic ovary syndrome, irregular periods, and infertility. Because of obesity, she had a gastric bypass at age 27, which was well tolerated. She lost a substantial amount of weight. Her periods became regular, and she had 2 normal pregnancies. Gastric bypass and bariatric surgery in general is a risk for these patients if they are known to have AHP, because it can compromise nutrition and precipitate attacks, but this did not occur in this patient. She also developed symptomatic gallstones and had a cholecystectomy at age 27. At age 35, she began having multiple emergency room visits for unexplained abdominal pain, chest pain. She also had cardiac failure with low ejection fractions, which was never fully explained. At age 39, she developed multiple recurrent symptoms, including chest pain. She developed CNS symptoms, including tunnel vision and confusion. She was then hospitalized. She developed paresis, respiratory weakness, required a vent, and then this progressed to quadriplegia. And she was then discharged to a rehab center where she had another seizure, was admitted to a second hospital, and then transferred to a third hospital. At that point, she was diagnosed after 10 days in the hospital as having AIP, and she was treated with Hemon, and this led to improvement. And she improved considerably over that period of time, but she was left with some residual weakness of the distal extremities, particularly wrist drop and ankle drop. She continued to have monthly attacks, often requiring hospitalization, which thereafter were treated with Hemon. And she also developed chronic pain requiring chronic use of opioids. Her attacks on this treatment were less frequent. Monthly Hemon infusions are usually not very effective, but sometimes they may be. She noticed that her chronic pain improved for several days after each dose. At age 41, she was started on givosiran as part of the phase 3 study. She was on placebo for 6 months and did not improve during that time. She was then put on the open-label extension period, and during that period she had no acute attacks. Her chronic pain improved, although she still requires some opioids for pain. She is now transitioning to commercial product after completing the phase 3 study. So this case illustrates the efficacy of prophylactic treatment with Hemon and also particularly with givosiran, and the importance of recognizing the cause of the patient's symptoms so that effective treatment can be instituted. Now let's hear a patient's perspective.
When I started taking this new RNA therapy, it took about 2 months before it really kicked in good, and my attacks, my pain began to get less and less. I had far fewer and fewer attacks. I'm at the point now where I have very minimal symptoms, and I'm not certain that I can always, contribute the abdominal pain that I occasionally get to that. My nausea and vomiting's gone. I have absolutely no pain medication now at all. I have no medication at all for the nausea and vomiting. I'm actually able to go back to school. I'm going back to school for a degree in respiratory therapy. I'm working a part-time job, so I'm at the point now where I really only have 1 day off a week, and I'm doing well with it. I'm getting my life back, basically. I do safety labs once a month, about a week before my treatment is due. I go into an infusion center. They give me the shot. It's just a subcutaneous shot in the abdomen, and then they monitor me for 30 minutes to make sure there aren't any issues, which I've never had any issues with it at all, and then I leave. Some months I will have a phone call with the hematologist the day before, and some months I will go in and see him physically just before the injection. They'll review the safety labs, go over them with me. Everything for me has always been, perfect. I've not had any issues. The side effects from the drug have been very, very minimal. Just a little bit of fatigue is all. So for me personally, it's worked out very, very well. For family, for those that are taking care of these patients, please understand that there are going to be days in which they are very, very grouchy. They just don't feel well. There are days that our mentation is not very well. There were days I couldn't even hold a conversation. I would have to tell my wife, we just have to stop the conversation. I cannot process what you were saying. I need to go rest. There were a lot of times we would have conversations that I simply did not remember. So please understand that particularly when they're having a lot of pain and they're on these higher doses of pain medication, we're not going to remember things. We're going to be confused about what you're saying. Please be patient with us. Let us rest. Please understand we're going to have bad days. We're trying our best not to snap back at people. We feel confused. We feel misunderstood. And we feel like our life has been taken away, like really we feel like oftentimes life isn't worth living anymore because we're in such pain so often that we would rather things just end. For the caretakers, if you can go to their appointments with them to see their doctors, go with them, because we don't always remember everything that's going on, and sometimes you will see things from a different perspective or remember things that we are forgetting that you can tell a physician. It's really important to communicate everything to the physicians so that they understand everything that is going on from different perspectives. I never realized how depressed I was, and so my wife had brought that up to the physicians. I was finally able to get my depression treated. We don't always understand how severe the pain really is. I can tell you there were many trips to the ER that I just don't remember well, that I don't recall exactly what I told physicians, and so sometimes my treatment plans didn't go quite probably as well as they should have been. But, no system is perfect, so sometimes those things are going to happen. Just try to help us communicate with our caretakers.
In conclusion, it's hard to overemphasize the importance of providing a timely diagnosis of AHP so that patients can overcome the debilitating effects of the disorder with treatment options, including new treatments as they become available. I thank you very much for your participation and for your attention to today's program.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/HYK860. This activity is supported by an educational grant from Alnylam Pharmaceuticals Incorporated. This activity is accredited by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.